Good afternoon. I'm Dr. Jaime Estrada. I'm the president and board chair of Texas Doctors for Social Responsibility. Welcome to our January 29 biweekly public health lunch conversation. Today, we are honored to have Dr. Ray Perryman as our guest speaker. Dr. Perryman will discuss the many economic and fiscal benefits to our state of accessing additional federal funds for health insurance expansion. Dr. Perryman's study was first published on December 14 of 2020. Today, Manu Quintada, our medical student board member and co-host, is having an interview. She will be joining us later, so I get the pleasure to introduce Dr. Perryman. Dr. Perryman is president and CEO of the Perryman Group, an economic research and analyst firm based in Waco, Texas. His firm has served the needs of more than 2,500 state, national, and international clients. Dr. Perryman holds a BS in mathematics from Baylor University and a PhD in economics from Rice University, as well as an honorary doctorate from the International Institute for Advanced Studies. Dr. Perryman has authored several books, over 400 academic papers, and more than 2,500 trade articles. He publishes an annual subscription forecasting service and monthly newsletter. He writes a weekly syndicated column and hosts a daily radio commentary with frequent appearances on National Public Radio. Of all the many recognitions Dr. Perryman has received in his career, the one which I found most compelling is the Cesar E. Chavez Conscience Builders Award, which he received in 2016 for his humanitarian efforts. Dr. Perryman has been named the most quoted man in Texas by Texas Monthly, the unofficial state economist by the New York Times, and his personal favorite, the state's premier barbecue connoisseur by the Dallas Morning News. Please join me in welcoming Dr. Ray Perryman.
Well, thank you, Jaime. It's a pleasure to be here with you and to spend a few minutes talking about this topic. He mentioned the study that we recently released came out in January 2020, or I'm sorry, December 2020. But I have been involved in this issue for a long time, and literally a very, very long time. I was on the board of a health company. I retired in 2019 for 30 years. It's called Healthcare Service Corporation, which may not sound familiar to you. It operates a number of insurance plans, including one in Texas known as Blue Cross Blue Shield. So you've probably heard of it. And so that and my professional practice kept me involved. And I was involved with some of the groups that originally put the Affordable Care Act together and looked at it. And it was far from perfect. There were a lot of problems with it. The dynamics of how it got passed were very strange and unusual, and caused some things to get into the bill that probably shouldn't have been anyway. But the goal was very good. The goal was to try to provide healthcare pretty much universally across the board, give everyone access to some type of healthcare insurance. And the way they planned to do that for the lower income individuals was essentially to expand Medicaid, the program that has been available and for a number of years. And the way the program works is states pretty much get to determine who's eligible, who's not, and that sort of thing. And then there's a matching system based on relative income and things like that. The way it works in the historical program, roughly speaking, Texas gets it's about a 60-40 match for Texas. That is 60 cents of federal money for 40 cents of state money. So the state has to put in almost half the money, and then the federal government provides the rest of it. Each state gets to set the parameters that of how they operate it. And as you probably, if you know anything at all about Texas politics, you wouldn't be surprised to know we're about the stingiest state in the country when it comes to that. We provide it only for pregnant women, mothers of small children, those that are blind and disabled. Literally, about the smallest group you can get by with. And we also have some of the lowest reimbursement rates, which is something that's probably near and dear to your hearts. We have some of the lowest reimbursement rates in the country as well. So we have, for lack of a better name, a pretty stingy program. But the Affordable Care Act, as it was originally designed, was going to make this Medicaid expansion mandatory for all states, and hence we would have had a mechanism to cover the poor individuals, particularly poor adults in the state of Texas. Now, as you probably know, it was very controversial. It immediately, the name changed in popular parlance from the Affordable Care Act to Obamacare, which was an anathema to a lot of folks in the leadership in Texas and other states. And it became a lightning rod for a lot of things. I think a lot of people, if you could have a different name for it, might have felt differently about it. In fact, many of the provisions of it were actually written by a Republican think tank. But once it got the name Obamacare, it became, as I say, a very difficult thing to deal with politically. And there were a number of challenges to its constitutionality in the court system. And in the major challenge, the first major challenge that happened, the Supreme Court ruled that the law was indeed valid, but there was just one part of it that they couldn't enforce, and that was they couldn't mandate that states do the Medicaid expansion, that it became optional. Now, the day that ruling came down, I happened to be in a place every summer. I had to do it virtually this year, but every summer, the last, I don't know, 20 years or so probably, they've been kind enough to invite me up to the Chautauqua Institution, which is kind of a think tank retreat thing up in Western New York near Buffalo, and participate. It's really one of those things that kind of gets the juices flowing, rejuvenates you, makes you think positively about things. You mentioned the humanitarian award I won a few years ago. I think most of our humanitarian work was probably conceived in those very pleasant surroundings. But in any case, I happened to be up there when the Supreme Court ruling came down. And our governor at the time, Rick Perry, we disagreed on some things, but we're very good personal friends. We've known each other a very long time. His wife actually worked for me for a few years. So, I mean, we go way back. And so when the Supreme Court ruling came down, I called him and said, I know you're not going to expand Medicaid, and I'm going to do everything in my power to make it as miserable for you as possible. So that's how I became involved in the Medicaid expansion issue in Texas in a big way. And I've since worked in a number of other states and helped them design their programs and that sort of thing. At that point, we started doing studies looking at the economic impact of it on the state. And the one we just finished is the latest one, and the one that takes account of all the recent research and data. Now 38 states have the program in place. We've had an ability to observe it and see how it works other places, and that enriches our ability to do research about it and that sort of thing. So basically, the way the process works, the first year or so was 100% match. The federal government paid for the Medicaid expansion, and it provided coverage to anyone who was at or below 138% of the poverty level. In round numbers, for an individual, that's $19,000 or so. For a family of four, it's a little more than that. But I mean, fairly low income individuals would have health care or health insurance provided by the government and with the federal government paying for it. And once it became optional, most states that were, for lack of a better name, what they now call red states, opted not to do it. But over time, a great number of them have decided, yeah, this makes sense. And the match was at first 100%, then went gradually down over a few years and got to 90%. And then it stays there perpetually. So basically the bottom line is right now, to bring more health dollars into Texas, for every $1 the state put in the system, the federal government would bring $9 into the health system. So, and as you know, with the system being strained on resources right now and that sort of thing, that can make a big difference. And that's a very, very big leverage situation. And so we started modeling what the economics of that would be. And we went back and forth. We've been in several legislative sessions with arguments back and forth about it because it's never passed. But we this time around, we're hoping with the pandemic and other things to get a little bit of momentum toward it. Frankly, I don't see enough support to get it past this session. I really don't. And I see enough opposition by people who are in a position to prevent it from happening that it's probably not going to happen. But that doesn't mean the fight's not worth having. The more people we can inform, the more time we spend on it, I think the better chance we have going forward. Just a little bit of background. Texas has an uninsured rate of 18.4%. That is 18.4% of our population does not have health insurance. The national average is 9.2%. We are twice the national average. And keep in mind, I know if you're med students, you've had a little bit of math along the way. We're 10% of the US economy, and our 18.4 goes into that 9.2. You know, we bring the average up. So literally, if you took us out, the average would be even lower. And so basically, our uninsured rate is over twice the national average. It's the highest in the country. And for a state this large, that's very unusual. Those kind of distinctions usually go to much smaller states and affect far fewer people. So it's not a distinction you want to have. For the states that have now adopted Medicaid expansion, the average uninsured rate is now 7%, because it qualifies a lot of people. In our case here in Texas, roughly around 1 million people would qualify for it. And so the issue then becomes, would the state be willing to put in $1 in order to get $9 from the federal government? And the answer thus far has been no. It's too expensive, we can't afford it, that sort of thing. All of the research, and we have done several studies on it, and we're probably the most cited source on it, but the Kaiser Foundation has looked at it. Some university researchers have looked at it. This thing has been very, very widely analyzed. And we may differ a little bit in the numbers, but the ultimate conclusion is always the same, that it just makes sense to do this. And something that was done this year by some colleagues and I, this time around, before we did the study that was mentioned earlier, we took a look at, let's forget all the economics, let's forget all of the indirect effects and multiplier effects and how it works and all that, and let's just look at the state budget for a second and pretend you can put a box around it and just look at the state budget and nothing else. And some very competent folks took a look at that, including Randy Fritz, who's a former administrator, chief operating officer of the health department in Texas for a very long period of time, very knowledgeable of the ins and outs of the budget and how it works. And even if you look at it on that basis, the state would have to put in their piece of the money, their 10 cents for every dollar. But in doing that, they would be able to save some money inside the state budget. For example, right now, a fairly simple example, most of the health care for prisoners in Texas is funded out of general revenue. Well, if you expand the adult population that's under 138% of the poverty level, a vast majority of that group qualifies. So all of a sudden, 90% of that money would come from outside the state rather than general revenue. That's one example. Some other programs the state maintains. Anyway, we just scrubbed the budget, or those really, Randy did the heavy lifting on that. Scrubbed the budget, took a really hard look at it, and they would get back more than the dollar before you ever do any economic analysis. Okay, so they would come out ahead before you do any economic analysis. And 4 or 5 scholars, Dr. Vivian Ho from Rice, some of you may be familiar with, very prominent health economist, Dr. Laura Day from Texas A&M, Randy and myself, all prepared a letter and sent out to all the legislators and that sort of thing, just making that point before we get to the economics. Okay, so even if you put all that aside, it just makes sense for us to do this. And I keep saying, politically, if you're a liberal and you want to help people, this is a good program. This gets 1 million people access to health care. Okay, if you're a conservative and you really don't care that much, super conservative, not so concerned about that, but you want to save the state money, it also makes sense. So it's the kind of thing that should be bipartisan. Unfortunately, it's become politically polarized. We looked at the economics of it, and here's kind of how that works in a nutshell. And then I'll give you a few of the numbers, and then I'll open things up for questions, and we can have a discussion about it. But beginning more than 40 years ago, I started building some very, very big economic models, first of Texas and ultimately expanded to the entire world, that give us the ability to do a lot of very detailed modeling of how things work together in the economy. Now, they're not perfect. We, unlike a lot of the disciplines you practice in, we don't have the luxury of a scientific laboratory where we can do a controlled experiment. Because in the real world out there where we all live, you can't hold everything else constant. But so what we have to do is we have to build a mathematical structure that captures it the best we can. It's certainly not perfect. There's a lot of randomness in human behavior and everything that drives the economy, obviously. But we build this model that's like a structure of, this is what the world looks like. And then once you have that model in place, you can go in and change one thing and see how it looks with and without that one change. And through that, you can begin to see what the impacts are. So it's a social science attempt to do a scientific experiment. It's imperfect. It's not as accurate but it generally gives you fairly decent order of magnitude effects because we have a lot of information, particularly now that we've had enough time in this case to see what other houses work in other states, that sort of thing. We have a really decent set of data to work with in this case. Dr. Laura Daig, I mentioned a moment ago down at Texas A&M, did a very, very deep dive on literally down to the county level, how this thing plays out in a direct manner. And she was kind enough to share that data with us to use in our study. So there's a great deal of detail that went into this. Now, basically, there's three major channels. There's a lot of things going on in the economy all the time, but there's three major channels that happen when you put more money in the healthcare system. The first one is obviously you get more spending. I mean that's a no-brainer. All of a sudden, this would bring in about 5.4 or so with the population growth. It would probably average over the next 2 or 3 years close to $6 billion a year into the state that are not there now to be spent on healthcare. So obviously, just a mere fact of doing that, of providing that much more healthcare, provides some real benefits to the economy. A second phase of it is when you don't provide healthcare, and again, I'm sure most of you on this call know this, but when you don't provide a mechanism for indigent folks to have access to healthcare, basically they have one way to get access to healthcare, and that is to walk in the emergency room door. If they walk in the emergency room door, you have to do something with them. You have to get them stabilized, try to help them a little bit. And as you're well aware, that's the most expensive door in the most expensive building in the healthcare system. And normally that becomes what is basically called uncompensated care. That is, they come in, they get whatever help they're going to get, and they're not able to pay for it. Now, the money to pay for that comes from a couple of sources. One is taxpayers, because most of the uncompensated care, well, actually three, many physicians and other folks in your profession donate a lot of time to this. But beyond that, the two places you get actual dollars in the system are counties that have public hospitals. Basically, you have a tax rate that supports those hospitals, and a chunk of that has to make up for these dollars they don't collect from people for whom they provide a service. And the other place is those who pay private insurance premiums pay more, because part of what they have to do to keep the healthcare system viable is provide some revenue to offset this uncompensated care. Now, if you're the typical individual, middle income or lower middle or above, you're going to pay county taxes and you're going to pay insurance premiums. So you're in essence going to be paying for it out of both of those pockets, so to speak. And so getting that money where it can circulate the economy with the healthcare still being provided provides a certain amount of benefit. That's not a huge number in the grand scheme of things, but it's big enough to be worth incorporating and talking about. The third source of economic impact is you have a healthier population. And when you have a healthier population, that means people don't miss as many days of work. People are more likely to be gainfully employed. They're more likely to be able to send their kids to school, so they can have better jobs in the future. They're more productive. The mortality rates are improved. The morbidity rates improve. You have more years of work life. And there's been a great deal of public health research that helps us quantify all of that and put it together. So we basically throw all that into the system and say, what does it look like with Texas with Medicaid expansion and without Medicaid expansion? And you notice the title of the report you may have noticed is called Expanding, or something like Leveraging Federal Dollars. We sometimes avoid the phrase Medicaid expansion because politically that's a tough sale. People don't like it. They don't like the name. There are other ways to do it that technically don't invoke Medicaid. There's ways to get there. If we can get the willingness to engage with us, we can figure out a way to do that. I've helped a number of states get all the money without calling it Medicaid expansion. There are ways to do that. But the bottom line is, when you put all that in there, very big economic impacts over the next biennium, because we did some 10-year analysis in the report. We also did what if we had it now, but we really focused on the next biennium because legislators think in the 2-year budget cycle. They've just convened down in Austin, and the one thing they have to do before they can go home is write a budget. They can do a lot of other things, but they constitutionally they can't go home until they get a budget. And so that's the focus they always have is this 2-year budget cycle. which can create a lot of issues when you're trying to deal with issues like long-term health care. I worked on some issues like diabetes and cancer and that sort of thing. And obviously you can't put those in a 2-year cycle, but a legislator's mind thinks that way when they're writing a budget. And so basically, over the next biennium, we discovered it would bring in about $46 billion in gross product. That is in new production in Texas as a result of having this in place versus not having it in place. A portion of these results, most of them kind of just grow a little bit with population and that sort of thing, but a certain percentage of them compound over time like an annuity, because the more years you provide healthcare, the more you improve the productivity, the mortality, the morbidity statistics, and that sort of thing, and you create a more productive workforce on an ongoing basis, which that starts to have like an annuity. It starts to sort of compound a little bit and give you some bigger effects as you go out into later years. But that was, that was the effect we had. That translates into around 460,000 years of work, job years, creating jobs for folks to work for a year. So those are significant numbers. It also generates about $2.5 billion in extra revenue for the state after accounting for the money they put in. So the state comes out with a big increase in their budget. To put that in perspective, state revenue over a biennium is roughly a little over $100 billion. So 2.5 billion is a pretty significant number in that. It also brings up local revenues. A final thing we do in these studies always, just for communication purposes, is we talk about things not only on a aggregate basis, because even for you rich doctors, $45 billion probably sounds like it's a hard number to get your arms around. So we talk about on a per dollar basis, for each dollar the state puts in, what happens. And it's about $30 in extra output to the economy. But here are the numbers they tend to focus on that we're really trying to talk about right now. For every dollar they put in, they get back $1.95 in what's called dynamic fiscal revenue. That is tax dollars coming back. And let me take just a second to explain that, because that gets into a little bit of economic jargon. The state typically thinks in terms of what's called static revenue. And that is, they pretend, when they analyze the budget, they pretend that nothing they do has any impacts outside the budget. They just look at that. So if you say we're going to spend $1, the economic impact of them is $1. It doesn't matter what happens with that dollar. Okay. And that's where we went. That's why we did that initial analysis. It said, even if you look at it that way, put a box around the state budget and don't do anything else, then you still come out ahead on the money because of the way you can move money around and that sort of thing. You still come out ahead. But dynamic revenue is where you say, okay, actions have consequences. And when you play those consequences out, what happens is $5 billion will get spent on healthcare. Some of that ends up in the pockets of providers. They go out to the store and they buy stuff and they pay sales tax. So they buy a little bit bigger house and they pay property tax. Or they go somewhere in the state and spend a night or two and they pay occupancy tax. And so that's we begin to bring all of those things in. We bring all that in, the state gets back $1.95 and local governments even get $1.58, and they didn't put the dollar in to start with. So it's a pretty good deal for them. The county taxpayers' tax burden goes down by about $1.50 because they're not subsidizing the indigent care anymore. Okay, so that's an aspect of it. Most of these bills have they put parity with the Medicare rates and the Medicaid rates for reimbursement. So that's good for your profession, because right now the Medicaid rates are so low that many physicians simply can't afford to take Medicaid patients because the rates are so low. Most of them do take Medicare patients. They're still not as high as private pay, but Medicare is a decent rate. Most people can live with the Medicare rate. This brings it up to parity. So all those things flow out and bring tax dollars back in. Okay. It also saves people about 50 cents every dollar they put in. I think it's 48 cents in insurance premiums, because again, your private insurance is not subsidizing the providers for the uncompensated care that they have to provide. So that's another way that works its way through the system. And then and a final number I put in there, because again, I work on a lot of issues around poverty and hunger and those kind of things, and certainly this past year has brought those in, is for every dollar the state puts in, it will bring in $3.09 more in lifetime earnings for the folks in that indigent health group that get health insurance as a result of it. I think that's that's not necessarily a number that resonates always with the legislature, but I think it's a very important number from a social perspective and one that's worth talking about. The final thing I will mention is about this is these numbers are obviously, where we have to make assumptions, we make them in a conservative way. We try to understate, but a very important place where we really understated these numbers is we use the most recent data that's fully available, and that is 2019. So we did not factor in, you had another million Texans lose health insurance this year. 1.4 million Texans lost health insurance because of the pandemic. Some of that's temporary, some of it will come back. Probably 300,000 or 400,000 of those, in addition to the million I was already talking about, would be eligible for this program. And so the benefits are actually would be even larger. So that's in a nutshell, that's what we did. That's why we did it. We are, we're providing, several legislators have filed bills. There's been a lot of hearings. There's been a lot of meetings. There's a lot of talk. It has more buzz this year than usual, probably because of COVID. I am not optimistic that it will actually pass this time around, but I think we at least are in the process of educating some folks. A particular piece of traction we're getting this year, interestingly, and probably not surprising to think about it, is the legislators that represent districts with rural hospitals. Because rural hospitals are having a very, very difficult time now. A huge percentage of their patients are indigent or Medicare, and a lot of the indigent ones do not have insurance. And this would provide a lot of resources to sustain those rural hospitals. And there's been a study done, Kaiser did, look at the states that have Medicaid expansion, the states that don't, and the difference in the rural hospital survival rate was staggering. And so a lot of those legislators, as they've heard from the constituents about the problems this year, they're a little more focused than usual on this. So there is more attention to it. I'm not sure there's enough to get us over the finish line. So with that, I can't read the chat, but I'm assuming somebody else is reading it. I see some questions coming in. So yeah. I'm happy to try to take your questions.
Okay, thank you, Dr. Perryman. It's hard to understand seeing all the benefits that the expansion could bring to Texas economy, why the legislature cannot open their eyes and take the federal monies out sitting on the table. That's something that we can't understand.
Yeah, and it is very difficult to understand, and it becomes political, as you know. We have a polarized world right now, and it becomes politicized in ways. And there's a lot of myths out there. I mean, the majority of the people who will be eligible for this, they're working. Okay? The myth is they're all just lazy and they don't want to do anything and they just want to live off the government. That's not true. That's a myth, and it wakes its way into some people's minds and think about it that way. That's not the case. It's simply not the case.
So one of the questions, and this is quite relevant right now, because as you know, the waiver, the 1115 waiver was approved for another 10 years. How is that going to affect the legislative decisions?
Well, what happened was during the final 4 days of the Trump administration, we slammed together an agreement, and they extended the 1115 waiver, most of it. There's a piece of it that provides some mental health care and some rural health support that's going to expire in September, about $2.5 billion. But most of what we had before has been extended for 10 years. Now, the practical effect of that is we need that money, obviously. That's been sustaining us. We'll still have that money for the next 10 years. So it kept us from falling off a cliff, so to speak, that we will still have most of that money, but it didn't insure a single new person. It didn't provide any more health care if anybody didn't do anything to affect our uninsured rates. Again, it kept us viable and sustainable, and I'm glad it passed. So that's the practical effect of it, is it kind of maintains most of the status quo, with the exception of we'll lose some funding for mental health, for some rural health initiatives and things like that, which is unfortunate, but it will maintain most of the status quo.
Right.
The political reality of it is, though, it gave folks who are looking for a reason not to do Medicaid expansion to say, wow, we just got our waiver, we don't need it. So it's having a political effect. A lot of the folks who were talking Medicaid expansion before have suddenly become pretty quiet. So
Yeah.
it is
Yeah.
having a political effect. Economically, it basically maintains the status quo. And that's a very good question. I should have mentioned that before. I'm glad that was asked.
So one of the questions is if Texas accepted the Medicaid expansion, would it give the responsibilities to managed care organizations, or would HH take it over?
Well, there's, you can set it up any way you want to. I mean, it's the bottom line. I mean, there's a lot of flexibility in how you set it up. I suspect, knowing the dynamics of Texas, that there probably would be a fair amount of it that would be run by managed care organizations, I would think, just given kind of where we are now, the attitudes about health programs and that sort of thing. There would be something like that. Some states have insisted on things like a little bit of a copay, because just so the people have some skin in the game. I don't know why you ask a person who's living on $17,000 a year to pay $20 a month or something, but there's a little bit of that goes into some states have done it that way because that's the only way they can get the votes. And we might be in a situation like that at some point, but I suspect managed care would be a pretty big part of it.
I see. Can you explain how disproportionate reimbursement for uncompensated care works?
Well, basically what happens is the person you will now have 1 million people whose only practical access to the system now is to go to the hospital, generally to the emergency room. They will now be insured. So they will be like anybody else that walks in the hospital or the doctor's office or the clinic or PA's office or whatever. They'll have an insurance card that they will hand someone and they'll have coverage. And so, there will now be dollars coming from the federal government that pay for some of that, the dollars now that are paid for by, like I say, county governments, insurance premiums, those kinds of things. Now, another thing some people say is, well, that's just, we pay federal taxes too, so we're paying for it anyway. Again, you have to think about it. In the way this works, that's really not true. The federal government hadn't balanced the budget and paid its own way in 50 years. In fact, we first became a debtor nation in 1789. In essence, no one in Texas taxes go up or down depending on whether we take Medicaid expansion. It's dollars we get back, so we wouldn't get back otherwise. But our taxes are not going to change as a result of that. So that's another thing you hear there. And I rambled a little bit, but that's basically how it works.
Yeah. And so the federal government commitment to provide the dollars for the expansion, is that an open-ended issue?
Yeah, and that's one of the things you hear critics say, well, what if they quit doing this? By statute, it is perpetual at this point in time. Now, Congress could change that at some point in time, but that would be a very, very difficult thing to do because you now have 38 states who have it. Right. And if their representatives really thought it was going to go away, they would do something to try to replace it, bring it back. Because once you have it, people become accustomed to it, and it's very popular among the groups that have it. And I think we saw some of that in, back when President Obama was president, and for a while you had a Republican House and a Republican Senate. They voted to overturn Obamacare, I think 46 times or 61 times or something like that. If they didn't like what was on the lunch menu, they'd just go ahead and overturn the Affordable Care Act, knowing that he would veto it. Had he actually vetoed it, they would have known what to do. I mean, had he gone along with it, had he not vetoed it. During the Trump administration, they tried very hard to vote it, but even when they had Republican House and Republican Senate, they couldn't get the votes to pass a bill to get rid of it. So I say all that to say it's entrenched right now. Yes, by statute, it could conceivably change or conceivably go away, but it's one of those things that once you have it, it's very difficult to take away. And now well over 2/3 of the population of the country is covered by this. And so I think that's very safe. I mean, I don't think it's going anywhere at this point in time. Even if one of these Supreme Court cases that Texas and other states file should happen to be successful, I think you'd immediately see Congress come back in and change the law enough to reinstate it, because it now has a very popular base, and it's good populism sometimes to vote like that, and they get brownie points with the party and that sort of thing. But realistically, they do that knowing it's not going to matter at the end of the day. I mean, that's the politics of what's going on right now.
Right. One of the things that I may have missed is that those federal dollars are our tax dollars.
That's right.
Right, that are supporting other states' expansion.
That's exactly right. We pay the taxes whether we get the benefit or not. Our taxes don't go down because we're a non-expansion state. Our taxes wouldn't go up if we were an expansion state. That's exactly right. And again, you have to recognize, I'm not saying this is the best way to provide health care. There may well be a better plan. We can sit down with a blank sheet of paper and write a better plan. This is the plan that's in place today, and this is the ground rules we've been given. Given these ground rules, the only thing that makes sense is to leverage these dollars and bring it into the system. I mean, you guys, some of you are out in the trenches every day. You know what this is like right now, and I admire what you do and how you function in the system that we have. But this could make it a lot better.
Our Councilwoman Ana Sandoval wants to know where is the report? Where can we see?
Very good question. Very good question. It's several places. My website is perryman.group.com. You can go in there and download it. There's no charge, and you just go in there and download a PDF. And you can do the report, or there's a technical appendix. We did this again in trying to communicate with the legislature. We provided results by county, by city, by legislative district. So there's a couple hundred pages of tables in this thing that you may or may not want to look at. But so you can download just the report, or you can download.
Great.
It's also available on the Episcopal Health Foundation website as well. So you can either get it from our website, perrymangroup.com, or the Episcopal Health Foundation has it.
Good.
I'm aware of it.
Excellent. So there are other questions. Let me go through this real quick. We have still a few more minutes.
Sure. I'll stay as long as we need.
Ray asks, with COVID-19, many hardworking parents have lost jobs. More kids now qualify for CHIP and Medicaid, but the parents have lost health insurance for themselves. How would they get coverage? I mean, this is the main issue, right?
Point of COVID has made it much worse, and frankly, it's made it possible to have another substantive conversation in Austin about it. Without it, in the last couple of sessions, they pretty much said we don't want to talk about it, and that was pretty much it. But if you have lost your health coverage and you qualify under these income levels, then you would immediately you'd be able for Medicaid immediately to cover you. As you say, there's coverage for children now, but you'd have coverage. You would have the Medicaid coverage if you were able, if we had the program in place. In many states, we've seen this happen because obviously we've seen a lot of people. We estimate, again, our estimate is that 1.4 million people have lost their health insurance in Texas from layoffs this year, and that's a huge number. Not all of them of the threshold or whatever, but a good chunk of them would qualify for this. Ease this burden that the number of families are suffering right now. This pandemic, as you all know, it's created huge problems in health, in hunger, in mental health issues, and domestic violence issues. It's been a really, really tough situation for a lot of people. It's created a lot of desperate situations.
Okay. Pat Herden has a question. Pat?
Yeah, I've got several degrees in anthropology, and some of the people that trained me were political anthropologists. So I spend a lot of time at the interface between what's considered to be economic and what's political. One of the things that I learned about the Texas legislature, that they, at least since the Republican takeover of the legislature and the state house and so forth, is that money that comes from other sources, federal sources, and even internal sources, tends to get stuck in some kind of a trust fund somewhere that's held by each agency. And they use that money to balance the budget, which is the only thing they have to do, and get the comptroller to stamp it. but they don't ever spend, but they're reticent or may even never spend that money, billions of dollars that are stuck in these trust funds on their intended purpose. And I see that as that's a big problem. And now we have a problem for this coming legislature, well, this legislature that we're already in now, which is that the census reports are not coming out. So this legislature is not going to have to be, is not going to be able to deal with the problems that have to do with redistricting in this legislature, although anybody that's ever been there knows that that's still going to be a problem, and it will still be an excuse for not doing anything else, and they'll have to call a special session just to deal with redistricting. And so I'm kind of curious what you think the impact that's going to have on how money's actually spent. You know, we're involved with a rural health initiative here, and the only way I can see to create a rural health network in this state right now is through Medicaid funding, because no private insurance company will go out there and address that issue. And so there's a whole mixture of issues here that are kind of dependent on the state budget and how it's spent. And I wonder if you'd address some of that.
Sure, I'd be happy to. And I've been dealing with the Texas state government since I guess the 1979 session. So I've been in a lot of these scrapes over the years with both parties in power. And you're absolutely right about some of that. In fact, the state even has property tax values have gone up rather than providing all the money they're supposed to for schools. They let that increase in property value substitute for state dollars. They'll even take county money and use it to balance the budget. I mean, there's a long history of that sort of thing here in Texas. Most of the money that's ended up in these trust fund sort of things has been like transportation money, things like that. The way the Affordable Care Act is structured, they can't actually just hoard this money. I mean, they would have to actually spend the money. Now, what they could do, and what frankly we're encouraging them to do, is again, they could do things like move a big chunk of the incarcerated care into the Medicaid exchange as opposed to the general revenue budget, which that's how they get back the dollars that they have to put in. So as we're trying to show them, you really don't have to put anything in. You know, we told them basically how to fix the budget. And so there are some things like that they could and should do. It would make things more efficient. But I mean, this is going to be a very difficult session because they have a tough budget situation. As you mentioned, we had the census is drive redistricting is always the dominant theme in the sessions where it comes about. I think they're supposed to get the census around the beginning of May, which is only a few days before the session is over. Right. So they may well find themselves, probably will find themselves in a special session dealing with that. But they're very focused on budgets. The draft budgets that have come out obviously don't include this, and they include some cuts in some other areas that are pretty draconian, frankly, including public education. So I mean, it's going to be a difficult thing to deal with. I mean, it always is. But this money is set up in such a way that it is, you know, it's basically part of an insurance program. So it does go. It does get spent. I mean, it doesn't get hoarded. It does get spent. But so we don't have that issue so much here. But all the other issues you mentioned are a big problem. And I think again, probably the biggest problem this year is when you combine the pandemic and the potential for redistricting, is just getting them to focus on anything but a budget and redistricting. I mean, that's one thing that happens is just the four corners of that budget that's already been submitted by both houses and the draft, just getting people to move much beyond that is going to be fairly difficult this time. I mean, there'll be some things I'm sure they want to pass some voter legislation, and they want to pass some first one thing and another with a new administration in to try to blunt what they see as problems there. But by and large, it's going to be a session that's much more narrowly focused than a lot of others, and the complications of meetings and having hearings and that sort of thing that we're facing. All those things are making it more difficult than it normally is, and it never is easy. So I feel your pain.
Yeah.
Well,
sorry, but I think we run out of time. Thank you so much, Dr. Perryman.
My pleasure.
We really enjoyed your presentation. Lots of great data. Hopefully, we'll get some momentum and all the
Yeah,
coalitions, all
if
the
I could
people
take, if I
working on
could
it.
take 10 seconds.
Yes.
A wise man once told me a long time ago that the best lobbyist is not as important to a legislator as the worst constituent. So let them know how you feel.
Right.
Through your association, but also just individually with your individual legislators, let them know
Yes.
how you feel. That's very important.
Great. Okay, well, thank you again.
Thank you.
And thank you to everyone who took time to be here with us and Dr. Perryman. And we'll see you again in 2 weeks.